Hi, everybody. I'm really glad to be together with you during this webinar. I'll talk about our coming issues in the inositol therapy, the alpha-lactalbumin. And this is the agenda. First part of my lecture will be devoted to inositol resistance. I remember 2013, the International Consensus Conference on inositols in obstetrics and gynecology. We put several questions, obstetrics and gynecology and assisted reproductive technologies. A paper came out focused on twin metabolic syndrome and PCOS, and as already Fabio and Mariano mentioned, treatment with inositols reduce insulin resistance, hyperandrogenism, hirsutism, and acne, and restores hormonal balance and metabolic. The system production technology, and it pointed out that inositol therapy restores ovarian function by inducing ovulation and improved oocyte quality embryo. So 5 years recently, this expert opinion on inositols in treating polycystic ovary syndrome and non-insulin dependent diabetes mellitus.
Zarko,
the evidence suggests that
Zarko, excuse me if I interrupt, but because your voice it's not really stable. Try to be more near to the computer and to check for your line. Thank you.
Okay, how it is now?
Okay, it's good.
Okay? Good. So, and my topic now will be about one of the updates, which includes the new evidence on the efficacy exerted in the PCOS 42-1 Mayo-to-Dikiro, the innovative approach based on alpha-lactalbumin to overcome the decreased therapeutic efficacy on inositols in some patients. So, we already know that Mayo alone or Mayo plus Dikiro improves insulin sensitivity and improves oocyte quality. But as you know, in this famous movie, nobody is perfect. So around 30 to 40% of the patients do not ovulate with Mayo, and we call them Mayo-inositol resistant. What is the problem with this? We know that the homeostasis of Mayo-inositol, it was pointed out just before me, depends on the intestinal absorption, carrier-mediated transportation, endogenous synthesis and catabolism, and kidney excretion. So inositol deficiency may be caused by decreased biosynthesis and or transporter activity. We know that there are two types of transporters, the sodium and the proton coupled, and only SMIT2 is found in duodenum and jejunum. Also, it may be caused by inhibition, competition of intestinal and cellular uptake by different interfering agents. For example, Dikiro-inositol has a lower Michaelis constanta than Mayo, and this means higher transporters affinity. So it's very important not to give too much Dikiro-inositol because it will interfere with the transportation of Mayo. And glucose, it has 100 times lower transporter affinity, so it cannot cause problems. But if there is a huge amount of glucose, then it could also happen. Very important are the abnormalities of intestinal absorption due to chronic inflammatory states and reduced food-dependent intake and increased catabolism or excretion. So as you can see, most of the mechanisms already mentioned as probable for inositol deficiency are related to the gut. And we have a very good myo-inositol and dikero-inositol option for improving the PCOS patient conditions, but we of course have to do it even better. And as Henry Royce said, strive for perfection in everything, take the best that exists and make it better. If it doesn't exist, create it. Accept nothing nearly right or good enough. So the second part is about the gut microbiota and the metabolic syndrome. Today, we live in the civilization of obesity and diabetes. This is because it took 5,000 generations to become a human being, and then only 5 generations to become a Homo McDonald's or Homo computers. So the circumstances have changed, but our genetics did not. And today we have the metabolic epidemics. It is not the simple link between more food and more fat. There is also a missing link, and this is the gut microbiota. Gut microbiota means all the bacteria we have in our gut, and the the microbiome means the genome of all these bacteria. It is only one part of the many microbiota in the skin, vagina, etc. We live with this bacteria. It's normal to have them, but they have to be in a very good proportion. So we have 10-fold more bacteria in the human gut compared to our cells, to eukaryotic cells. And at birth, the gut of a neonate is sterile, but quickly becomes colonized by the bacteria derived from its mother's birth canal, the external environment, and the food. There are about 1,000 different bacterial species in the adult bowel, and the dominant are Bacteroides, Firmicutes, and Actinobacteria. The global interest to gut microbiota increased starting somewhere at the end of first decade of this century, and this is because the obesity and diabetes pandemics, surgical treatment of obesity and diabetes, and GLP-1 receptor agonist treatment of diabetes and obesity. Gut microbiota has a very important role, physiological role. It is important for the synthesis of vitamins. It makes the protection, immune system development, promotion of intestinal angiogenesis, promotion of fat storages, short-chain fatty acids production, and modulation of central nervous system. So gut microbiota related are very important processes like the control of appetite. In the arcuate nucleus, here are the agouti-related protein, and also the CART, cocaine, amphetamine-related peptide, propiomyelanocortin, etc., centers for hunger, for satiety, etc. Another mechanism, this is the neural mechanism. The gut has very good developed neural system, and through the vagus nerve, the vagal afferent nerves, it affects the nucleus tractus solitarius, etc. But gut open for the immunity and inflammation. You see here the microbiota and many other cells from the immune system which are affected, stimulated, or suppressed. There are many diseases which are linked to gut microbiome and this biome. Cardiovascular disease, we know that atherosclerosis is a low-grade inflammation condition. Also central nervous system, Alzheimer, etc., IBD, etc. disease. This is a very interesting Chinese study. They characterize the gut microbiome composition of 655 twins, mono and dizygotic and their families, and about 18% of them had metabolic syndrome. They related to lower gut microbiota diversity and abundances of several taxa like Suterella, Methanobrevibacteria, and Lactobacillus. And protective were the Akkermansia, Odoribacter, Bifidobacterium, but they were decreased in the patients with the metabolic syndrome. And they found also that the Bifidobacterium deficiency has highest heritability. So they concluded our results suggest that an altered microbiota composition mediated by a genotype can contribute to the development of metabolic syndrome. This is a very short scheme. Everything starts with high-fat zinc or other aspects of the Western type diet. There is a change in gut flora, increased permeability, increased lipopolysaccharide absorption, and this is a toxin, increases endotoxemia, inflammation, and causes the metabolic disorders. So through the diet, age, lifestyle, genetic, antibiotic usage, we may cause dysbiosis of gut microbiota, and this may cause further obesity, IBD, diabetes, cancer, and autism. This is not a privilege of the humans. Also in the insects, we can talk about the metabolic syndrome and their gut microbes, and also in small mammals like mouse. Gut microbiota, this is an ancient time bomb for the metabolic syndrome, and this has to be taken into consideration. The most important, this is our lifestyle and what we eat. The third part is the dogma hypothesis. This is a new piece in the pathogenetic puzzle of PCOS. Nothing new. Hippocrates, 410 years before Christ, wrote in the Sentience, the causes of bareness in the women are the fatness and moistness of their flesh, which are such that the womb cannot absorb the seed. Their monthly purging is scanty and late, while the mouth of the womb is closed and does not admit the seed. They are personally fat and lazy. Abdomen is cold and are the causes. These are the causes which make them infertile. And now, a clear proof is afforded by their slave girls. This because of their activity and leanness of body. No sooner go to a man than they are with child. In his famous Banting lecture, Revan positioned the PCOS in the so-called X syndrome, and this is the prototype of the metabolic syndrome by Fabio about the pathogenesis, the role of hyperinsulinemia, hyperandrogenemia, insulin resistance for all these diseases. And we know today that there is something more, and this is the microbiota and the inflammation, which should be included in the pathogenesis of the PCOS. So we know that microbiota is important for the development of PCOS. I'm sure there is also existing the opposite link, but it is much less studied. And we talk today about the dogma dysbiosis of gut microbiota. There is a reduction, proven reduction of alpha diversity, increase of lipopolysaccharide production bacteria, decrease of spore-forming species. So you see that all the aspects of development of the metabolic syndrome related to gut microbiota are also present in most of the, I shouldn't say in all, but in most of the PCOS women. And PCOS is linked to a leaky gut. Inflammation causes hyperandrogenism. In our group, we studied many different markers, organokines, adipokines, hepatokines, myokines even. For example, myeloperoxidase, monocyte hemoattractant protein, fetuin A, anti-proBNP, etc., in women with PCOS, showing that they are at increased risk. But this was just mentioned by Fabio. And today we have a new piece in the puzzle of PCOS, and this is the gut dysbiosis. I'll talk about myoinositol and alpha-lactalbumin, and you see that human milk, this is an orchestra of benefits, and here is also the microbiota effects. Alpha-lactalbumin, it is a milk serum protein. It is 40% of human colostrum, but it is around 20 to 30% of the human milk proteins. And you have to mention that it is the percentage of alpha-lactalbumin is much higher in human milk compared to the bovine milk. And human milk has much less protein compared to cow, goat, and sheep. Much less calcium, much less phosphorus, but much more carbohydrates. And here is again the proportion. 88% of the human milk, breast milk, is water, and these are the other ingredients. I tried to find, I made review in the PubMed about the alpha-lactalbumin, and more than 4,000 results were found. The first one, the lactalbumin, was in 1896. Can you imagine what about was this first paper about obstetrics and gynecology and Worcester method of rendering cow's milk, which is believed to be poor in lactalbumin, as nearly as possible and equivalent for mother's milk. This is from Boston Medical and Surgical Journal, more than 1 century ago. And here you see that there is a steep increase in the interest to lactalbumin. Why? Because in this paper from 1966, they wrote, alpha-lactalbumin, a major constituent of the whey protein of milk, has been recognized for some 20 years, though no biological function other than a nutritional one could be ascribed to this protein. The present results suggest an enzymatic role of alpha-lactalbumin as one of the subunits of lactose synthesis. And further on, 4 years later, again about this enzymatic function, some experiments were made. So today, patients, most of the infant formulas contain alpha-lactalbumin, and it is included by the FDA in the list of generally recognized as safe GRAS substances. So this is very important, and this means it is safe. Alpha-lactalbumin is used by the bodybuilders. Its synthesis is induced by prolactin. It's highly thermostable. Its main function is to induce the lactose synthesis in the breast milk as protein B. It has a bacteriostatic activity, mainly gram-positive, and antiviral functions. Furthermore, it is a prebiotic, mucoprotective, anti-inflammatory, immune modulating, and trophic. There are many papers. I have no time now to focus on the many papers showing these options for alpha-lactalbumin. So PCOS is linked to gut microbiota alterations, and it is an inflammatory status. ALAC restores the flora, thus improving the physiological nutrients absorption, and it has reduces inflammation and consequently the hyperandrogenism of PCOS. ALAC is very rich of tryptophan, and tryptophan is the base amino acid for melatonin, and we know that melatonin is very important for many aspects of the reproductive function, especially for the follicles, and also ALAC is poor in ALAC is also a carrier for vitamin D and for divalent metal ions like calcium and iron. So we have the myo-inositol and we have the ALAC. Small things make perfection, but perfection is not a small thing, as Henry Royce said. And what about the combination of them? Much was insulin sensitizing, FSH sensitizing, and many other functions, positive functions. But ALAC is also anti-inflammatory, melatonin synthase inducer, and improves nutrient absorption. So there is a very good combination. It's a synergistic between myo-inositol with the effect on insulin resistance and ALAC with the effect on inflammation and microbiota alteration. Finally, I'll show you two papers which I consider very important. One of them is the paper of Giovanni Monastra. It's only with 18 healthy patients, 7 men and 11 women, but it has to show the effect of alpha-lactalbumin on myo-inositol intestinal absorption in vivo and in vitro. They were able to show that the area under the curve, when using compared to the curve with myo-inositol only. And also the Cmax was 30%, 32% higher here at this point compared to the myo-inositol only. So ALAC improves the myo-inositol absorption. It's very important without changing the pharmacokinetic. The maximum comes here on the 180 minutes. But actually, is it the actual mechanism, the improvement of myo-inositol absorption? They continue to the very important part. They use the CACO2 cell line, and this is the best available model for small intestinal mucosa. CACO2 cells make monolayer on the permeable polycarbonate filters. So this mimics the enteral wall, the enterocytes. They use the transepithelial electrical resistance. This is a measure of the transportation, and also phenol red passage, again a marker of transportation through this monolayer of CACO2 cells. They applied in two concentrations, 5 milligrams per liter and 10 milligrams per liter. And what they found is, you see, this is the myo-inositol transportation when the myo-inositol was applied only. This is the combination with 5 milligrams per liter, and this is the combination with 10 milligrams per liter concentration. it was much higher. So the higher concentration of ALA transported or helped in transportation of myo-inositol much more compared to the smaller one. And this is one of the conclusions. You should use enough alpha-lactalbumin in order to have the effect. And these are the other effects, this transepithelial electrical resistance. The higher the resistance, the less the transportation through this model of a membrane. And you see with myo-inositol, with the small dose and with the larger dose, 10, it was much higher. So the higher dose caused an increased transportation. This is a proof that exactly the transport through the enteral wall is the effect of ALAC. But also the phenol red passage was able to show that there is an opening in tight junction between the cells, but it was not a continuous one. These tight junctions were opened for a special period of time and then closed again in order to stop the permeability of the gut wall.
Zarko, please conclude.
Yeah. Okay, 1.5 minutes. So they concluded better myo-inositol absorption when orally administered with alpha-lactalbumin can be beneficial in non-responder patients. Preliminary in vitro findings suggest that peptides deriving from alpha-lactalbumin digestion may modulate tight junction permeability, allowing increased absorption of myo-inositol. And the second paper, this is the paper of Mario Montanino Oliva. In 2 phases, in first phase, they gave their patients only myo-inositol to 37 patients for 3 months. And in the second patients, those of them who were myo-inositol resistant took myo-inositol plus 15 milligrams of alpha-lactalbumin twice a day. These are the inclusion criteria, exclusion criteria, and the primary endpoints were restoration of ovulation in myo-inositol resistant patients and increase of myo-inositol plasma levels in myo-inositol resistant patients. These are the levels of myo-inositol in the responders. They are 2 times higher in the myo-inositol not responders or resistant. So those of these women who had higher levels of myo-inositol, they ovulated much more. And in the second part, the women who were myo-inositol resistant with 17 micromolar per liter myo-inositol plasma levels increased twice their levels by alpha-lactalbumin. There were many other benefits from this treatment related to total cholesterol, triglycerides, testosterone, free testosterone, dehydroepiandrosterone, and SHBG. All of them were improved. And I can conclude that myo-inositol resistant patients show a lower myo-inositol plasma level than non-resistant ones after myo-inositol treatment. The combination is able to induce ovulation in the myo-inositol resistant patients, resistant to myo-inositol alone, and alpha-lac seems to increase myo-inositol absorption.